Okay, so today let's talk about the pelvic fractures. Let's divide the pelvic bones into separate bones and then discuss the fractures of each bones. First, we'll be starting with the sacrum. In the sacrum, we have two types of fractures, the horizontal or transverse fracture and the vertical fracture. The horizontal or transverse fracture is the most common fracture here, and this usually involves the S3 and S4. The view that we will use here is either an AP view or a lateral view or an AP with tilt up 35 degrees caudally. Okay. If the horizontal fracture, instead of occurring in the S3, S4, they occur somewhere here, S1, S2, this is named as the suicide jumpers fracture because of obvious reasons, because whenever a person is trying to jump off from a very tall building, he might get these fractures here. Similarly, we can also have vertical fractures. These vertical fractures of the sacrum are usually due to an indirect trauma, and here only the AP views are useful. Lateral views are not so much useful. Let's move on to the fractures of the ilium. In the fractures of the ilium, we first have the iliac wing fractures. Because it was first named by Duvernay's, so these iliac wing fractures are also known as Duvernay's fracture. These iliac wing fractures usually occur due to a direct force hitting on the iliac wing from the lateral direction like this. This is usually known to be a stable fracture because of the reason that the iliac wing is covered by very large muscles, hence even if fractured, they do not usually get displaced. The X-ray view useful here is the oblique view. These Duvernay's fractures or the iliac wing fracture either can be a simple linear fracture or they can also be a stellate fracture like this. Next, let's move on to the Nalgene fracture. Nalgene fractures consists of two vertical fractures. However, important point to remember is that these two vertical fractures occur in one single hemipelvis. Two injuries to one hemipelvis. What are these two vertical fracture? Number one vertical fracture is involving the superior pubic rami and the ischiopubic rami. Okay, this is right, this is left. One fracture involving superior pubic rami and the ischiopubic rami. Next fracture is a fracture dislocation of the SI joint like this, a fracture and or dislocation of the SI joint. So only one side is involved. Double vertical fractures. Here is one vertical fracture. Here is one vertical fracture. 1, 2. Double vertical fractures in one side. This is Nalgene fracture. Okay. The next fracture we will talk about is the bucket handle fracture. For a bucket handle fracture to occur, we need an oblique force. Okay. We need an oblique force. Here, both of the hemipelvis are involved. Suppose, as the picture suggests, this is the side of impact and this is the opposite side of impact. So what will be the fracture on the same side of the impact? On the same side of the impact, we have a fracture and or dislocation of the SI joint. On the opposite side, we will have the fracture that we saw in Nalgene, that is a superior pubic ramus fracture and the ischiopubic junction fracture. A superior pubic rami fracture and the ischiopubic rami fracture. So one fracture is on the ipsilateral side of the impact and the other fracture is on the opposite side of the impact. This is what we call the bucket handle fracture. Next fractures are the acetabular fractures. To know better about the acetabular fractures, we need to understand its parts. So this is the iliac bone. This area is the wing of the iliac bone. The bone here is the iliac crest. This is the anterior superior iliac spine. This is the anterior inferior iliac spine. This portion of bone here is the sciatic buttress. This is the part of the ilium which connects the axial skeleton with the appendicular skeleton. We have the greater sciatic knot somewhere here. Now this entire portion on this side is the anterior column. Posterior portion excluding the iliac wing is the posterior column. The acetabular fossa, this portion is the anterior wall. And the posterior portion here is the posterior wall. This is the obturator foramen, the superior pubic rami, the inferior pubic rami, and this is the ischiopubic rami. Then next, now a schematic representation of the same. This yellow portion here is the anterior column, and this is the anterior wall. Similarly, on the posterior side is the posterior wall, and this portion here on the posterior side is the posterior column, and the part here that is remaining, this we talked about, was the sciatic buttress. Then let's move on to the 5 major fractures involving the acetabulum, but before that we need to know certain lines. Okay, these are the lines that we need to know. Number 1, the iliopectineal line. Number 2, the ilioischial line. Number 3, the posterior acetabular wall. Number 4, the anterior acetabular wall. And 5th, the obturator foramina. The obturator foramen. Now, whether or not these structures are getting disrupted will tell us the kind of fracture that has occurred to the acetabulum. The most common fracture that we will be talking about is the both column fracture. In both column fracture, we have anterior column is fractured, posterior column is fractured. Anterior column is fractured, and this fracture also extends, as we can see here, up to the iliac wing. Does this fracture extend up to the obturator ring? Yes, definitely the obturator ring is also involved. One more sign that can be seen, which if present is pathognomic but may not be always present, is the spur sign. What happens here? The sciatic buttress is displaced posteriorly. So here the anterior column is involved, that extends up to the iliac wing. The posterior column is involved, and it also extends up to the obturator ring. So which of these lines are going to get disrupted? Remember, the disruption of the iliopectineal line is considered to be equivalent to disruption of the anterior column. Disruption of the ilioischial line is considered to be equivalent to disruption of the posterior column. Hence, here in both column fracture, there will be disruption of the iliopectineal line. There will be disruption of the ilioischial line. Along with that, the obturator foramen margins will be disrupted, and not just that, you will see that the fracture has extended up to the iliac wings. Next, the second fracture is a T-shaped fracture. In this T-shaped fracture, what are the differences from the both column fracture? Here also anterior column is involved, but very important, it does not extend up to the iliac wing. Here also the posterior column is involved, and here also there is extension of fracture into the obturator wing. So if this is so, what are the lines that will get disrupted? Anterior column is involved, so iliopectineal line will get disrupted. Posterior column involved, so ilioischial line disrupted. Obturator foramen involved, so obturator foramen margins will get disrupted, but there is no iliac wing disruption. The next fracture is a transverse fracture. In transverse fracture, as we can see in the image, anterior column is involved, posterior column is involved, but neither is there any extension to the iliac wing, nor is there any extension to the obturator ring. So as a result, there will be disruption of the iliopectineal line, ilioischial line, without any disruption of the margins of the obturator ring, without any disruptions of the iliac wing structure. And this fracture is usually limited to the acetabulum. Let's move on to the next fracture, which is a transverse fracture, but there is extension now to the posterior wall. Not the posterior column here, I am talking about the posterior wall. Okay, so here, just like the transverse fracture, anterior column is involved, posterior column is involved, iliac wing and obturator rings are not involved, but as an extension, there can be a fracture of the posterior wall, which is usually comminuted and may or may not be displaced. Next, the last one is an isolated posterior wall fracture. Here, there will be posterior wall disruption with or without involvement of the posterior column. So, we are done with the acetabular fractures. Acetabular fracture was the fourth one. We will continue into the fifth type of ilial fracture, which is the avulsion fracture. Avulsion fracture is very simple. It is tugging off of the bone from its point of attachment due to a pull of the muscle. Hence, these fractures are also known as tug lesions. So, a small fragment of the bone will get detached and displaced. Okay. So, in the ilium, the usual regions where the avulsion fracture is going to happen is the two important sites of bony attachment. Number one, the anterior superior iliac spine, and number two, the anterior inferior iliac spine. So this might get displaced laterally like this, and the anterior inferior iliac spine usually gets displaced inferiorly like this. Muscle attached and gets involved in avulsion fracture of the ASIS is usually the sartorius, and AIIS, the muscle that is involved and causes avulsion, is the rectus femoris. Next, let's together talk about the fractures involving the pubis and ischium, and in this we will not just talk about the fractures, we will talk about the fractures, the dislocations, and the pubic diastasis. Let's talk about the fractures first. Number one is the straddle fracture. In the straddle fracture, there is a double vertical fracture. Two other double vertical fractures that we had learned is the Malgainie fracture and the bucket handle fracture. In Malgainie fracture, there were two vertical fractures which were present in only one side of the hemipelvis, whereas in bucket handle fractures, they were present in opposite sides. Here in straddle fracture, there is bilateral involvement. Whatever happens, there is a bilateral involvement. So what is the involvement? There is fracture of the bilateral superior pubic rami and the ischiopubic rami. Again here, superior pubic rami and the ischiopubic rami. It is unstable fracture. It is usually comminuted, involving the pubic arches. Any other fracture? Yes, we get avulsion fractures in the pubis also. At the level of the symphysis pubis, it is usually the adductor muscles that get avulsed, and the site is either the superior pubic rami or the inferior pubic rami near the pubic articulation. The second avulsion fracture is from the ischial tuberosity. This is due to overuse of the hamstrings and avulsion of the hamstrings. So what happens is, at the ischial tuberosity, there is a secondary growth center. If there was a ischial tuberosity avulsion fracture, over time what will happen, there will be an overgrowth of the avulsed fragment. Initially, there will be a gap between the original ischian bone and the avulsed on the fragment, but later on they may join together and you may find there is a overgrowth hypertrophied ischial tuberosity. These are often seen in horseback riders, and therefore this is known as the rider's bone also. Okay, so avulsion fracture is done. Let's move on to the dislocations. A very important named dislocation is the sprung pelvis. What happens here, as you can see in the picture, is there is a complete separation of the symphysis pubis and complete separation of either unilateral or even bilateral SI joints. This is called the sprung pelvis. Because this looks like an open book, this is also named open book pelvis. Next is diastasis, and in diastasis we have the pubic diastasis. There is a shearing separation between the pubic articulation at the symphysis pubis. So the normal distance between the pubic articulation in children should be up to 10 mm, and in non-pregnant adults it should be up to 8 mm. If anything more than 8 mm in non-pregnant adults, it is a pubic diastasis, and in children anything above 10 mm, it is a pubic diastasis. So I have tried to cover as much as possible of this chapter. If there is something that I have missed out, please do comment below. Okay, so see you in my next video.